All right, look, let's 9:02. So let's get started. Some folks may jump in, and that will be fine. We'll kind of bring them all up to speed. My name is Dr. Christina Johns. I'm the senior medical advisor here at PM Pediatrics. I'm the spokesperson, and I'm going to be moderating tonight. I'm here with my colleague and good pal, Dr. Eric Weinberg. He is our Vice President of Education. He's a dad, he's a husband, he's a friend, and he is going to give us a nice presentation tonight. You know, I think there's been a lot to synthesize, right? A lot in the news, a lot in our Facebook groups, a lot of stuff that you think, what is real, what isn't. Even in the mainstream media, I think sometimes it can really be hard to distill down the science to know, hey, is this science that I need to pay attention to? Is this science that I need to be more skeptical about? And so we're going to try to do that synthesis for you here in a brief 25 to 30 minutes or so, and then we're going to answer some questions. People in this audience sent in over 100 fabulous questions that were very on point, very relevant. We obviously are focusing on children, which is our area of expertise, but also not a topic that has been focused on. And so I think that will be good. So a couple of housekeeping comments. What we're going to do is Dr. Weinberg's going to present. He's going to talk for, say, 20 to 30 minutes or so. He's going to talk fast, and right, and then after that, we'll start to answer some questions. What I have done is I have tried to synthesize and pull into themes the questions that you guys all mailed in, and so that is how we'll try to tackle it. Remember that we can't really offer individual medical advice on this Zoom chat because we don't know necessarily all of the details on the ins and outs of your specific situation, medical history, and that kind of thing. So keep that in mind, but we will do as best a job that we can to answer questions in themes. In addition, in the chat, I've got some of my colleagues, Dr. Gary Gerlacher, who is our Vice President for Business Development, Kristen Crandall, who is a fabulous pediatric nurse and is our Director of Quality and Safety. We'll have Dr. Karen Sadow, she's our Senior Vice President for Quality, and Dr. Michael Bachman, who is our Senior Vice President for Clinical Operations. They are going to pop into the chat as well and identify themselves and try to help answer some questions so that we can get through as much as we can. We will not have any political agenda tonight. This is all about science and medicine and just trying to present the facts. So with that in mind, let's begin, okay? And Dr. Weinberg, you like to be a screen sharer, so I think you're going to share your screen.
All right.
Okay, take it away.
Hi, everyone. I'm going to get this started and then I'll introduce myself. Hi, everyone. I'm honored to have the opportunity to speak to you all today. I see we have over 400 people in the audience, which is pretty awe-inspiring. This is the second time in the last couple of weeks that I've told people on a Zoom call that this is the biggest audience I've ever had for a lecture. And it's interesting that I'm doing it out of my home office in Croton-on-Hudson, New York. But nonetheless, I'm honored to be here. I'm excited to inform you about certain things. My role at PM Pediatrics, I'm the Vice President of Education. And in that role, I develop clinical guidelines for our 50 offices, 300 doctors, and other amazing providers. And part of my role is to keep an eye on emerging illness. And so I've had a front row seat watching this coronavirus as it emerged in China in December, because in the back of my mind, I was always worried about what this would mean for our practice in our country. And we have spent, Christina, myself, and the rest of the coronavirus response team in our practice have spent hundreds of hours basically trying to digest the incredible amount of information that's out there and synthesize it for our providers so they know what to do. And we realized after giving a similar presentation to our group a couple of weeks ago, why not do it for you guys as well? And change some of the language a little bit, break it down, but take all of this incredible amount of information, synthesize it and present it to you so you can be informed as well. So that's what we're going to do today. So here's our objectives. We're going to talk a little bit about the history of the pandemic. We're going to throw out some facts about COVID-19. We're going to talk about symptoms and how it presents. There's going to be a focus throughout this lecture on children. We are pediatric experts. That's kind of our home base, and that's what we're going to talk about. We're going to mention COVID-19 testing. I'm going to talk about some treatment controversies. Pretty much every treatment for coronavirus is controversial because there's just not a lot of evidence out there, but I'll tell you what we have. We're going to bring it to a close with what you can do to protect yourself. And then probably the part that everybody wants to hear is I'm going to do my best attempt at predicting the future, which may or may not be true or not, but I'm going to do my best to take all the information we have and give you an estimate and a guess as to how we're going to pull ourselves out of this, because we will pull ourselves out of this, and I'll tell you how. But before we get to that, we're going to talk about how we got here. There are 7 known coronaviruses in the world right now. There's 4 that cause the common cold. There's SARS, which caused the initial SARS epidemic. There's MERS, the Middle Eastern Respiratory Syndrome, and then the novel coronavirus, which was identified in China in December. One thing that's important to mention is that the novel coronavirus occurred from natural evolution. This was not built in a lab. This has been well studied, and unfortunately probably evolved from bats, probably jumped through another animal, and then ended up in humans. One of the vectors for this may be an animal called the pangolin, which is prized in China for its scales and is present in some of these live markets that have potentially been shown as an area where this virus may have leapt to humans. And this is a similar path that coronaviruses take to humans. SARS went through civets and MERS went through camels to get to us. Moving along, the first patient reported with this virus was in China in mid-November. It was a 55-year-old person in the Hubei province. There's a possible connection to these wet markets with live animals. Following that, there was a cluster of mysterious pneumonia cases in Wuhan City. These were identified by a brave ophthalmologist who talked about this mysterious virus and unfortunately succumbed to the disease. And then this virus rapidly spread throughout China. Fast forward to January, this was the first case in the United States. January 21st, a 35-year-old male with respiratory symptoms presented to a hospital in Washington State with difficulty breathing and had a travel history and was hospitalized and discharged. So this is where it all began. We're going to fast forward again to early February. This is when we gave our first presentation on coronavirus. At this point, this seems like eons ago, even though it was only about 2 months. At this time, the virus was mostly centered in China. There were 11 US cases at the time, and there was no known community spread. And I know this seems like it couldn't even have existed, but this was not a long time ago. And here we are. This is as of this morning. There are now 3 million cases worldwide, including over 1 million in the United States. So a true pandemic, and obviously has been a source of real fear, and rightfully so. And we're going to talk about some of the facts about it. So let's get into the facts about COVID-19. How contagious is the coronavirus? The number that represents that is described as R0. And what this means is this is the number of cases that are generated by one sick patient. So the R0 for coronavirus is 2.5. And that means if there's no social distancing, if this one person walks around, this person would spread it to 2 to 3 other people. This doesn't sound like a lot, but if you compare it to flu, which is a pretty contagious illness, it's twice as contagious as the flu with an R0 of 1.3. Why is this important? Real simply, if this number is greater than 1, the pandemic grows. And if it's less than 1, the pandemic shrinks. Right now, the R0 in New York State is about 0.8 to 0.9, which means the pandemic is shrinking. But this is only with incredibly aggressive social distancing. Can you get COVID-19 and have no symptoms? Unfortunately, the answer to this is yes. Estimates of patients who do not have symptoms and yet have the infection are approximately 20 to 50%. One of my favorite studies about this is from the Diamond Princess cruise. I'm sure you guys remember this. This was a cruise that was going through Asia, docked in Hong Kong, and picked up a case with coronavirus, and then it ran rampant through the ship. The reason why this is a very interesting study is that they tested every single passenger and crew in the ship. So it's almost like a mini country of sorts. And they found 20% of patients or people on the ship were positive. And of those patients, approximately half of them had absolutely no symptoms at all. This is a huge point for people to understand because it has great implications for social distancing. You have to assume that everybody you see may have the virus, whether or not they have symptoms or not. If I have no symptoms, can I still spread the virus? The answer to that is unfortunately also yes. People with or without symptoms in studies have been shown to have similar amounts of virus in their bodies. As we just talked about, many infected people have no symptoms at all, even with active infection. And even those who are going to develop symptoms usually take about 5 days before they get sick. So this unfortunately means that this virus is both very contagious and hard to contain. How many of us have already been infected? This is a huge question, and I'm sad to tell you that the answer to this is mostly unknown, although we're starting to figure it out. There is a study that was published in the last week from New York of grocery workers that found 21% of these 3,000 people had evidence of previous infection with the coronavirus. A similar study performed in California and the LA area, there were several studies showed about a 2 to 5% positive rate. This is both encouraging and a little bit scary at the same time. How deadly is COVID-19? We're going to first talk about some early studies. The first published study on the mortality rate of COVID-19 came out in February 17th, and this is data that came from China. And the mortality rate in this study was about 2.3%. Just to give you a frame of reference, the current overall mortality rate for the entire world is about 7%, and for the US is about 6%. Why are those numbers higher? It's probably because most people who get the virus are not getting a test. So there's many cases that go undiagnosed, so that mortality rate is probably artificially elevated. One thing we do know is that the majority of coronavirus deaths are from patients with pre-existing conditions. We're going to talk about what those conditions are in a second. Another unfortunately scary statistic is that the elderly appear to be significantly at risk. For 60 to 69-year-olds, the risk of death in this study was 3.6, and for 70 to 79-year-olds, the risk of death was 8%. Unfortunately, this data has been correlated in many other countries, namely in South Korea, which probably has the best testing system in the entire world. They found actually 0 mortality in the less than 30-year-olds, which is somewhat reassuring, a 2% overall mortality, but the same very elevated mortality rate in the elderly. Keep in mind, again, many cases go undiagnosed, but on the flip side, there are many deaths, unfortunately, that may not be attributed to COVID-19 because they're not tested. Putting all these numbers together, several studies have looked at this, and looking at the New York data right now with our aggressive testing, the true mortality rate is likely in the 0.5 to 1% range. This doesn't sound like much, but if you compare it to flu, which kills tens of thousands of people per year, it's about 25 to 50 times higher mortality rate, which is certainly scary stuff. Which pre-existing conditions put you at higher risk? The big three are diabetes, obesity, and heart disease, in addition to compromised immune systems. The one good news on this slide is that early evidence suggests that asthma does not put you at higher risk for severe infection. Is COVID-19 in my community? Unfortunately, the answer to this is also likely yes. I don't know where you all live. There's about 500 of you on this call. But if you do live in the US, the answer to this is probably yes. The University of Texas and New York Times analyzed the probability of community spread in patients, or if there's a reported case in your county. So if there's, for example, 2 reported cases in your county, the probability of community spread is already 70%. And if you get up to 10 cases, that probability of community spread is about 95%. If you extrapolate that to a picture of the country, anywhere that's bright red means you probably have community spread. This is as of April 3rd. Given that it's April 29th, the entire map is probably red. So you must assume that it's in your community. We're going to switch gears, and I'm going to give you some good news for one. So are kids at risk for serious illness? And the answer is usually no. Serious illness in children is less common than adults. Studies both in China and the US show a much lower hospitalization rate compared to adults. And of those that are hospitalized, the great majority of these kids have pre-existing conditions. There are very few ICU admissions as well. Of those that end up in the ICU, the great majority have pre-existing conditions as well. But keep in mind, our hospitals are admitting pediatric patients every day. In particular, infants appear to be at slightly higher risk compared to other age group in the pediatric population. Some other slightly reassuring news: kids appear to have a very low percentage of just coronavirus in general. So out of all the tested patients, kids are about 2% of all cases. So they're really not getting sick that often, and when they do, it's usually not serious illness, although obviously there are exceptions out there. Just going to go back. Why are kids at lower risk? And unfortunately, the answer is nobody knows. There are certain theories. It's thought that kids have less ACE2 receptors in their lungs, and this is the receptor that coronavirus uses to bond to the cell and enter the cell and cause further infection. So if you have less of this receptor, theoretically, you get less illness. The other thought is that kids may have a higher level of antibodies to viruses in general, and in particular, the other 4 kind of coronaviruses that cause the common cold, and there may be some acquired immunity. So just some take-home points. I'm sorry I'm going fast, but I want to leave plenty of time for questions. But I always like to review the key points. COVID-19 is 2 times more contagious than flu and 25 to 50 times more deadly. The elderly, especially those with pre-existing conditions, are at high risk. Children and young adults are generally at lower risk, keeping in mind that infants and those with pre-existing conditions may have slightly higher risk comparatively. Coronavirus can be spread before symptoms appear or by people with no symptoms at all, and it is in your community. So let's switch gears. The next section, we're going to talk about the symptoms of coronavirus. What would happen if you actually got this virus? A good majority of you are going to have nothing, no symptoms at all. If you do have symptoms and you're of pediatric age, the most common are going to be cough or fever. But keep in mind, kids tend to present atypically. So right now, the CDC has identified 9 symptoms associated with COVID-19. The big 3 are fever, cough, and shortness of breath, but they just recently, this week, included chills, muscle pain, headache, sore throat, and loss of smell. Unfortunately, kids are always atypical, and in this case is no different. They may just present with throat redness or pain. They may present with vomiting or diarrhea. In my mind, anybody who presents to my office with symptoms of illness has possible coronavirus, and that's what I'm discussing with the parents. Adults tend to present more classically. Over 90% of adult patients have one of the big 3, fever or cough or shortness of breath. 60% of them will have body aches or headaches, and another 15% will have GI. These symptoms, unfortunately, can persist for over 1 week, and sometimes at that 1 week mark, they tend to worsen, and that's thought to be from the cytokine storm that you may have read about, which causes massive inflammation in the body. And this is where a home pulse ox may be helpful for you, and I'll talk about why in a couple of slides. Adults, unfortunately, have a higher hospitalization and mortality rate compared to kids. And unfortunately, this proves again that males are the weaker species. Males tend to be at higher risk for serious illness. The thought is this may also be due to higher levels of that ACE2 receptor that I keep mentioning. Loss of smell and taste. So I can proudly say that I misdiagnosed this in my own wife, who had symptoms at the early onset of this illness, persistently told me she has this mysterious loss of smell. I continually blew it off until we read in the New York Times that this is actually a hallmark of the disease. Approximately 30% of COVID-19 patients will end up with what's called anosmia, or loss of smell and taste. And the key with this is that it's often without sinus symptoms or congestion. So if there's a loss of smell or taste and there's no sinusitis, it's probably going to be from COVID-19. One other symptom we're going to talk about is rashes. This is coming up more and more. I don't know if any of you have heard about COVID toes, but this is a redness and swelling of the toes with associated pain that's caused by poor blood flow to the toes. And this is another one of those really unusual findings that's likely a hallmark of the illness. But there can be a multitude of other rashes. You can get mottling of the skin, which is called livedo reticularis. You could get a petechial rash, which is a fancy name for little bleeding into the skin that doesn't blanch with pressure. You can get hives. Really anything can be with COVID. And then I know probably 10% of the questions we received prior to this presentation was about Kawasaki and inflammatory syndrome. So a little bit of background, and then I could explain what's happening. Kawasaki disease is thought to be post-viral, and it's a constellation of symptoms. The big hallmark is prolonged fever, but then there are all these other symptoms that go along with it. And you may have some of these or all of them, particularly rash, swollen glands, cracked lips, strawberry tongue, red eyes, peeling of hands, and then another hallmark is irritability. The bad side of Kawasaki is that if it's untreated, it could lead to heart problems, specifically coronary artery aneurysms. So it's very important to diagnose this before day 10, because there is a treatment out there specifically called IVIG, which if it's given before day 10 will prevent any coronary artery aneurysms, but you need to be alert for it. Just this week, there were several cases reported in England and then in the last couple of days in the United States of this, what people are referring to as an inflammatory syndrome. It may be similar to Kawasaki in that they both have inflammation, but it may or may not have all of those classic findings. To be honest, I don't have a ton of information to give about this other than to be aware of it. We actually have had several cases present to our offices with this that have ended up hospitalized. One thing I think we should all look for, anybody with prolonged fever, we should be suspicious about this and consider sending screening labs because this can lead to inflammation of the blood vessels, heart organs. Also be aware, anybody who's looking particularly ill, this could be one of the causes, even without the prolonged fever. We're going to switch gears now and spend the next couple of slides on COVID testing. I know a lot of people have questions about this. I certainly have been digesting every single article on there about testing in regards to both PCR and antibodies. And I'm going to try to give you some of this information in an easy way to understand. So one thing that's important to understand, the US initially, unfortunately, lagged behind every major country in testing. The countries that tested aggressively managed this pandemic better than the ones that did not, because they were able to identify early cases, isolate them, and prevent them from spreading it to other people. We unfortunately did not do this, and it's one of the reasons why our pandemic in our country is worse than a lot of others. The good news is we're getting better. There have been recent improvements in testing, both in a private level and a government level. New York now leads the country in testing and leads other countries as well. And I think the reasoning is that there's universal agreement that we need widespread testing to reopen society. The only way you could safely open society is to identify any new cases, isolate them immediately, and talk to any of their contacts and isolate those people as well. That's how you control any new outbreaks from occurring once we start to reopen society. The two types of tests that are available right now are PCR and antibody. PCR is done by a nasopharyngeal swab. It's going to be most accurate in the first week of symptoms when you have the highest amount of virus in your body. And this is a sign that you are acutely infected and that you're also likely contagious. The problem with the current PCR is that about 30% of these tests can be falsely negative. The good news is if you're positive, you likely have it. The bad news is if you're negative, there's a 30% chance that you may still actually have it. This is currently being done in a widespread fashion in hospitals, urgent care centers, and testing centers, and we offer it at my institution at PM Pediatrics. Antibody testing is a little bit more controversial. This involves a blood draw, and it measures levels of antibodies to the coronavirus. The big two that most tests are looking for are IgM and IgG. To help you understand, IgM tends to occur early in the infection and is really not as important in developing prolonged immunity. IgG is the one that everybody's focusing on, and this tends to happen late in the infection. And the way to remember this is that IgG stands for Ig gone, which means the infection is gone, but this cell is still in your body and it's helping you fight this infection. The hard part is, as compared to PCR, which is accurate in the first 2 weeks, in the first week of infection, the antibody test takes time to become more accurate because it takes time for your body to make these antibodies. So it's really most accurate after 2 weeks of symptoms, and its accuracy continues to go up even after 3 weeks. Keep in mind, there's many unreliable tests on the market with bad accuracy. Specifically, the thing that most people are concerned about is that these tests, if they don't undergo an unbiased control from a lab, they may show signs that you've been infected with another coronavirus, as opposed to the one that's actually causing mortality. And nobody really cares if you've been infected with one of the 4 common colds. We want to know if you have the novel coronavirus that's causing, significant serious illness. So I would caution everybody to use a test that's done by a major hospital or a major lab, because these tend to be more reliable, because these labs have to do their own internal controls to make sure the tests are accurate. The early data seems to show that the sensitivity is about 80%, and I'll explain what that means. And the specificity is pretty high with some caveats. So sensitivity of 80% means approximately 20% of the people could be false negative. So if you get the antibody test and it's negative, that may be false, and you may have been exposed, and for some reason, either your body didn't generate the IgG antibody at all, or it hasn't been enough time since the time that you were infected. The specificity appears to be higher, which means if it's positive, you likely had it. But there's an important caveat to understand. If the virus is not very prevalent in your community, the specificity or the accuracy of the test is negatively impacted. So if you're in an area like New York, where the prevalence is about 20%, this test is going to be accurate. But if you're in an area where the disease is not very prevalent, the rate of false positives is going to go up. So keep that in mind. These tests are still early and nothing is absolute. Probably the biggest question we're going to get asked is, if I have the coronavirus antibody, am I immune? And unfortunately, the answer is maybe. What is known is that if the IgG is positive, that means you had the infection and now you have the antibody. What is unknown is whether this antibody equals immunity. The good news is there is some precedent here. In the previous coronavirus outbreaks, SARS in China and MERS in the Middle East, both of those had proven immunity after the initial infection as diagnosed by IgG. And this immunity would last anywhere between 1 to 8 years, which is enough time for us to make a vaccine to make you fully immune. In a perfect world, if we had time to study this antibody test, we could use it to theoretically, keep in mind, theoretically clear people for work or contact with vulnerable populations. But I caution you, we are not there yet. We need to obviously do this test because I think the knowledge and the information is powerful. And I think at some point it'll be very useful, but we cannot safely conclude that this equals immunity. That is the hope, but we're not there yet. What do we offer at my institution? We offer PCR testing and antibody testing. We'll actually start this week. We've been doing PCR testing for the last couple of weeks. To make sure we're using a reliable test, we use LabCorp, Quest, and we will likely start using Northwell when they start, because these are nationally recognized labs with high reliability. And these can be scheduled via our telemedicine app called PMP Anywhere. All right, we're going to switch gears again and talk about COVID-19 treatments, and then we'll talk about how to protect yourself and the future. We're coming to an end. Thanks for staying with me. So hydroxychloroquine, I'm sure you've heard about this from the federal government and read about it in the papers. This is an anti-malarial and rheumatologic drug. In cells, it has been shown to limit replication of the virus. There was one very famous, unfortunately very poorly designed study in France that did show a benefit in terms of decreasing the amount of virus in the body. But it was only about 30 patients and it was not a controlled study, meaning there may have been other variables that were causing this decrease in viral load. Unfortunately, since that time, there have been several larger studies that showed no benefit. And the problem with hydroxychloroquine is that there's potential harm. About 1 in 100 patients will have heart rhythm problems called long QT, and this could be potentially fatal. So we have to be extremely careful here. The take-home point is that this drug is no longer routinely recommended, certainly for use outside the hospital, as there is potential harm. More studies are needed. What about azithromycin? There is theoretical benefit. It's certainly antibacterial. Some studies have shown antiviral, behavior. But the problem with azithromycin, especially when used with hydroxychloroquine, is that it can also worsen this long QT or this heart dysrhythmia problem. And really at this point, the studies are quite limited. The only study is that tiny study of azithromycin and hydroxychloroquine that was mentioned earlier. That was the only study that showed any benefit. So the take-home point is there's really limited evidence of benefit for azithromycin with COVID-19. I would not rush out and take a Z-Pak if you're sick. There's really no evidence right now. What about Pepcid? This broke kind of this week, so I had to make a quick slide about this. Pepcid is an interesting story. The theory, or the reason why people started thinking about this drug is that in China, elderly people who had less money seemed to do better in terms of survival than elderly people with more money. And one of the thoughts is that Pepcid, which is far cheaper than other antacids, was taken more by these patients than other ones. Granted, this is a big leap, but this stimulated some researchers to look at the activity of Pepcid, and they actually found in modeling that Pepcid may inhibit virus replication. So there's actually a study going on in the Northwell Health System in Long Island, New York, that's looking at this, and the authors are saying we should hopefully have evidence of this within the next month. So again, I would not rush to the store to take Pepcid at this time, but stay tuned for news about this. Okay, next up is remdesivir. This is an antiviral drug. This literally came out today, so I just made this slide. The FDA is probably going to issue an emergency use authorization for this drug based on about a 30% shorter recovery time in patients who are hospitalized. So there is early studies that suggest improvement. Again, this is very early, but I felt it needed to be mentioned. There is potential benefit. This drug is not available for outpatient therapy, but it certainly has potential in the hospital system. Next up is steroids. So I'm sure you've heard a lot about this. We get a lot of questions about this in our offices. The theory is it could be beneficial because the coronavirus tends to cause a lot of inflammation in the body, or it could be harmful because it can also cause immunosuppression. The studies of steroids, there are really none in the new coronavirus. In the previous SARS epidemic, they were mostly inconclusive. So the take home really is that studies are limited. What I've advised all of our patients is if steroids are needed for another condition, you should absolutely take it, with the most common one being asthma. It's important for asthma to be well controlled as opposed to some theoretical risk. Ibuprofen is another one that a lot of you asked about. There is a theoretical risk because it may increase that ACE2 receptor I keep talking about. Unfortunately, there's a French health minister who spoke about this a little bit prematurely and said that ibuprofen may increase COVID-19 severity. Unfortunately, there's no studies to back this up. And then WHO came out with the most famous double negative in recent history and said the they said, we do not recommend against the use of ibuprofen. If you stare at that sentence for a while, you can figure out that you can probably use ibuprofen. So the take home, there's no evidence of harm. If you want to use Tylenol, that's certainly fine as well. Vitamin D is actually really interesting. There are a couple studies that were published this week on this. So this is another breaking news. There's theoretical benefit to vitamin D. It certainly seems to reduce the risk of influenza. There's a thought that winter viruses are bad because vitamin D levels are low. And there's a thought that elderly people and people with pre-existing conditions also have low vitamin D, and perhaps this is what's putting them at risk. There were two studies that came out this week. Shout out to Seth Weintraub, one of my smart friends in Croton-on-Hudson, who sent these to me today. And found there was one study that's actually really interesting. Looked at about 800 patients from Indonesia and found that those with the lower vitamin D levels had significant increases in mortality. Again, this is not a controlled study. It looked back on patients. They're not, it's retrospective, so you can only take it with a grain of salt, but the risk difference was pretty significant. There's another smaller study that found that ICU patients had lower vitamin D levels compared to those COVID-19 patients who were less sick on the floor. If you are interested in taking vitamin D, you can take 10,000 international units per day for several weeks and then go down to 5,000 units per day going forward. And there's really not much harm to this. So there is theoretical benefit to vitamin D, but pay attention to make sure no emerging studies come out. Vitamin C and zinc, unfortunately, not much studies about this. The benefit is really theoretical, and there's really limited evidence. There's really not much harm in this as well, other than some nausea with zinc. So you're welcome to take it, but I was unable to find any studies for you. One last warning, and this is the only political joke I'll put in there. Please do not ingest disinfectants. They may kill the virus, but they will also kill you in the process. I'll thank Dr. Gary Gerlacher for this wise advice. So what's our take-home points? There is limited evidence to support the use of hydroxychloroquine, azithromycin, and Pepcid. Potential benefit to remdesivir. There's no evidence of harm with steroids or ibuprofen, and there's theoretical benefit for vitamin D, vitamin C, and zinc, but there's a lack of good controlled studies. Next section, we're about 5 minutes away from finishing. What can you do to protect yourself? One of the biggest take homes I can tell you is that you must practice good hand hygiene. This is probably the most common way that the virus is transmitted. I'm going to show you some data as to why. But really, if you practice good hand hygiene and use hand sanitizers and don't touch your face, like I probably did about 14 times during this lecture, this will help prevent you from getting the virus. Obviously, you want to avoid crowds, but I do encourage people to get outside for your mental health. Do wear a mask when going out. One thing to consider, I'm going to spend a minute on this, is a home pulse oximeter. The thought is that people who tend to have worse outcomes when they get sick tend to be sick for about a week before they decompensate. And there may be a hidden clue in there of a lower oxygen level that's gradually decreasing over time. And if you can diagnose these patients quicker and bring them in the hospital and get them oxygen and support, you could avoid getting them on a ventilator. This is a $30 to $40 instrument. So if you can afford it, I would recommend picking up one of these to monitor in the event that you do get sick. Keep in mind, you have to keep your finger still and keep it on for about 1 minute to make sure that you're getting an accurate reading. One other thing I'd like to recommend is to support your local businesses. We've been ordering in from our local restaurants approximately 2 to 3 times a week in order to keep them in business. And you can do this in a safe way, which I'll tell you in the next slide. Please continue to be careful around vulnerable populations. And this is anybody greater than 60 years old and anybody with pre-existing conditions. The mortality rate is truly high for this population, and we must take great care. As much as we want to hug, my parents and my kids' grandparents, we have to hold off until the time is safe. And please follow your state regulations. Why is hand hygiene so important? There's a great study in the New England Journal of Medicine in mid-March that showed that the coronavirus can survive on surfaces for a scary amount of time. On metals, other than copper, it can survive for about 2 days on steel. It could survive for 3 days on plastic, and we live in a plastic society. And especially for those who are ordering Amazon about 15 times a week like we are, it can survive on cardboard for 24 hours. They did not test fabric, unfortunately, but the thought is that it can survive on fabric similar to the time it can survive on cardboard because they're both absorbent. So keep this in mind when you're out in the world. This is why hand hygiene is so important. Here are some ways to be smart and maybe some things not to do. So one of the favorite quotes, I can attribute this to one of the really smart people in our practice, Dawn Ritchie. She came up with the phrase, or I don't know if she took it from somewhere else, but told it to me, which is to be smart and not scared. So smart, not scared. Be out there and be smart. So I would advise, do not wipe your food with soap. This has a greater increased risk of toxicity because of soap residue. Do not waste time with gloves. Once your gloves touch another surface, they cease to be clean and then they just turn into your hands. So there's really no utility to wearing gloves. Just wash your hands religiously. Do not wash your shoes. You're probably going to transmit the virus from your shoes to your hand in the process of washing them. Simply leave your shoes at the door and wash your hands if you touch them. If you do work in a high-risk field like myself, please change your clothes, and I would even potentially recommend showering when you get home. This will prevent, hopefully, the virus from spreading to family members. For mail packages and delivered foods, please remove them from their containers, throw away the packaging, and then wash your hands, and you should be protected. If it's a non-perishable and you're in a vulnerable population or a pre-existing condition, you could consider leaving non-perishables in the garage for 24 hours for the virus to die on the cardboard. Most importantly, stay informed. Dr. Christina, who you already met, has an amazingly informative Facebook, Instagram, and Twitter account. My mother-in-law swears by this and is now almost as informed as I am about a lot of health topics. The New York Times coverage of coronavirus has been fantastic, as has the Wall Street Journal. Healthychildren.org is a great site for parents. There's a nice patient tracker through Johns Hopkins. The one thing I would warn you, though, is really to try to limit your intake of news and social media. Go on once per day, learn something, and then do something else, or it's going to be bad for your mental health. We have about 5 slides left, and I'm going to focus on our future. And this is the hardest part of this lecture, but I've told you a lot of things that are probably making you depressed, and now I'm hopefully going to lift your spirits and inspire you with the finish. So a couple of key points to remember about our society. Number one, we are flattening the curve. So social distancing is working. If you look at the number of deaths in the United States, we went up significantly. Right about mid-March, we put in place social distancing, and not coincidentally, about 2 weeks later, that's when the curve started to flatten, and we're actually on the downslope. And if you look, this is actually a really interesting projection from the Institute of Health Metrics and Evaluation, which has been accurately predicting this pandemic throughout. And the dotted line is the predicted area. So the solid line is the area where we are right now, and you can see the curve flattening. But the projection is, if we continue social distancing, that we will be at negligible levels or very low levels by June. And I'll explain why June is also a good month in a slide or two. But this projection, I hope, can allow you to sleep at night, and we could all hold it together for another month until things get better. Key point number 2, and this is where June comes in as well. Human coronaviruses display a strong winter seasonality. That means they're virtually undetectable in the summer months in temperate regions. The hope is that the SARS coronavirus, or SARS-CoV-2, will also be hopefully undetectable in summer months in temperate regions. Again, we don't know this for sure, but if it's another coronavirus and it behaves like the other ones, hopefully it's the same. And there are certain studies that suggest when the average temperature goes above 70, the spread of coronavirus goes down. So warm weather is on the way and may really help us. In addition to social distancing, key points to remember: if you take a high rate of asymptomatic people and you combine it with a highly contagious virus, which this is, and you combine it with the fact that this virus appears to have a low mutagenic rate. And the way I explain this is flu, which none of us have much natural immunity to, has a very high mutagenic rate, and it changes every year. The coronavirus so far doesn't appear to have a very high mutagenic rate. This may change, but that's how it appears right now. But if you put these 3 things together, at some point we're going to develop herd immunity. And that means enough people will be exposed and immune in the population to shut down this pandemic. I don't know when this will happen, but as long as the virus does not mutate, this will happen, and it will help us get out of this. Key point number 4, and I mentioned this earlier, other coronavirus immunity has typically, for other horrible pandemic outbreaks, just like this one caused by coronaviruses, typically lasts 1 to 8 years after first infection. This is key because we can now potentially test for this immunity. Again, this is all theoretical. We don't know 100%, but the hope is that this IgG may equal immunity. Stress on the may. Hopefully, some of us are immune, and this will carry us to the point, along with some warm weather, to successful vaccines. And actually read in the papers this week that both Pfizer and a lab in Oxford in Great Britain have both progressed to the level where they're testing vaccines on human beings. They both have coronavirus vaccines that were successfully tested in monkeys, and they're now testing in humans to see if they're both safe and effective. If this proves safe and effective, these could potentially be rolled out in an emergency method in September and the early fall, which would be great because a lot of experts are predicting a repeat bump of coronavirus in the winter, which hopefully we'll have vaccines ready for. So you take all these things I just told you. We're flattening the curve. We got warm weather coming. We got increasing number of people exposed or immune. We have antibody testing. If you put all these things together, we have hope. Okay, this is a picture of a little kind of statue that I had never noticed in my house. I'm telling the absolute truth here. It was just sitting in my house. I think my wife liked it and bought it. And I was at a low point during this coronavirus. Things were just going horribly. And I was terribly sad about what was happening in our world. And I noticed that this thing said hope, and I moved it, much to my wife's chagrin, to an area where I see it as the first thing I see when I leave my bedroom every day. And this, plus all the data I just presented you, is giving me hope that we can gradually open our society starting in May or June. Keep in mind, we must use a phased approach. We have to watch the number of cases after each change. And this is where testing is going to be critical, because we may have to go backwards. We may have, if there's a relapse, if there's an increase in cases, then we may have to tighten things temporarily and then loosen them again. This is the last thought I'm going to leave you with. A lot of people I've been talking to have been comparing this pandemic to a marathon. Some people are runners, some people are not. I used to be, before my 43-year-old body started to break down. And I did, by some miracle, successfully run the New York City Marathon in 2010. And it was hard. Not as hard as this, but it was hard. Marathons are 26-mile races. And I think, unfortunately, right now we are in mile 4 through 6. If anybody's familiar with the New York City Marathon, we're probably still in Brooklyn. And the bad news is you're probably already tired, which is not good if you're running a whole marathon. But remember, just like a marathon, you just have to keep moving forward. You don't want to think about the 18 miles ahead of you. What you want to think about is the next mile and getting through that. And the way I'm trying to think about my life is, I'm not trying to get to next September or next winter or past next winter. I'm trying to get to next week. And then I'm trying to get to June. And then I'm trying to get through the summer, where I hope things are going to be a little better. You also have to pace yourself just by running. Just like running, you have to eat, you got to drink regularly, you got to take breaks, you got to protect your sleep, connect with your friends. These are the things that are going to keep you going. And at some point, if you're anything like me, you've probably hit the wall about 14 times already. I certainly have. But what happens with running is you're going to hit the wall and you're going to keep pushing forward. And then at some point, you're going to look up and the finish line will be there. And that's what's going to happen with this. And I'm showing you a picture of the beginning of the marathon, because when I first uploaded this picture into the lecture, I kind of inhaled involuntarily because it was shocking to me, because every time I see a crowd of people right now, I get scared. Whereas before I saw this crowd of people and I was inspired. And soon, at some point, with all of the things I just told you, with vaccines, with warm weather, with herd immunity, soon we will do this again, I promise you. And we'll get to that finish line, and we can hopefully be as happy as I was in this picture.
That's great.
Thank you, and stay safe.
Thank you. Thank you very much. What a beautiful presentation. Eric, there was a question. Could you put up the slide at towards the end with the resources?
Absolutely.
So that people can know, here's what my take on the resource. This is what I tell people across my social channels, that if you see something online that you think that, oh, is this true? Is this not? What I recommend is try to cross-reference it with 3 places. So with a governmental agency that you are aware of, local academic institution, major academic institution, university, and or a health professional that you are aware of and trust. If you find that whatever it is you're looking up, the topic, if that checks out the same way in those 3 different places, you can be pretty sure or feel more confident that that's legit. And so I think that has served me very well. And so I just want to share that with you to kind of cut down some of the surfing that you may need to do. Couple of things. Will this presentation be around? Yes, we'll figure out how to get this up on our social channels, on our website, for people to access, so that
absolutely,
so that we can see. So yes, it will be available. I just want to take, before we jump into the questions, we will stay up a little bit later if you guys are willing to stay up with us and try to answer some more questions. But I want to pick up some of the themes really quickly that I saw that maybe we can answer a whole bunch of people's questions all at once. And that is, number 1, should you take your child in to see your regular pediatrician right now, or should you defer that visit? And here is what I would say to that. First of all, the American Academy of Pediatrics recommends that if your child is less than 2, then you should absolutely bring your child in to see your pediatrician for your routine well child care. And I will tell you that the overwhelming majority of pediatric offices, and we'll talk a little bit about what we're doing in our places, have made tremendous accommodations to keep people safe. And those are like the following. They're having people wait in their car until they're ready to be seen right away, so that they go straight to a room. So you're not congregating with lots of other people in the lobby or the reception area. In addition, many places are doing different timing of visits. So sick visits are only in the afternoon or at a certain time of day, and then all of those distancing procedures take place. I know at our places, we are being very intentional about this, from putting tape on the floor to make sure, kind of like in the Trader Joe's, where that you stay far away from other people, to making sure that people go right back to a room. For the COVID testing that we are doing, which I will talk about in just a moment, that is happening in some places outside. And so that is another way that we can really stay distanced. And I think that that is really important. So please call your general pediatric primary care office to see what they are doing and what accommodations that they are making now, so that you can continue to go and get your child care. We don't want to create another public health problem by seeing kids who are delayed on their immunizations, and we'll create another public health problem while we're trying to manage this one. So I think that's tremendously important. So that number one. Lots of questions that I'm getting too about masks and what's the guidance on that. So children under 2 really aren't going to be successful at wearing masks, right? They're the worst social distancers ever, and even on a good day. And so we know that to be true in very young children, certainly under 2, certainly under 12 months old. Masks can be a suffocation risk. Please do not put a mask on a child who is less than 2 years old. If the guidance really is that those kids, if at all possible, should not be going out at all right now, and if they have to go out for brief transports, covering your child carrier with a cover, even a little bandana kind of all over the head as you go into wherever you need to go for that brief transport. So that is an important one that we need to talk about. So look, another themed question. I'm going to toss this one over to you, Dr. Weinberg. Everybody is asking, gosh, when my daycare opens up, can I send my child back to daycare?
It's probably a very difficult, it's probably the most difficult question we see. Yeah. And I understand the trepidation there. I think at the end of the day, you probably have to defer to the regulations of your state. Right. If they are recommending that this is safe to do, then I think you can listen to that, as long as you trust that the state recommendations are being based on medical opinion. So I think that's a key thing to understand. I think overall the risk for kids is pretty low. And that is a reassuring take-home point that you should take from this. If they have no pre-existing conditions and you have no other alternative, then I think it's reasonable if your state allows your child to go to daycare, to have your kid go to daycare. Same thing with schools. Yeah. We've gotten a lot of questions about schools. What's that?
And summer camp.
And summer camp, yeah. So I'll talk about schools first, and then I have 2 kids who are sleepaway kids, so I feel your pain. Mm-hmm. Schools, I think, are the same thing. If schools open up and the state is basing on medical opinion that it's safe to do, then I think it's the right thing to do. We have to get our kids back to school, if possible, in a safe way. I think there's going to be some measures that are going to be taken to make the environment a little bit more safe. Nothing is going to be perfect. What we talk about a lot in our own practice is minimizing risk, not eliminating it. I think schools are going to do their best to minimize risk, just like we do, but I don't think anybody can eliminate it. And at some point, we have to open them up, and schools have to function because it's a main function of our society. It allows people to go to work and allows kids to learn and grow. So if your state says it's okay, I would go with that. In terms of camps, I've been looking for any kind of guidance on this. The good news is the federal government plan in their phase 2 response does mention schools and camps as possible reopening. That means we have to get past phase 1, which is a slow reopening without a bump in cases. So once we get past that phase 1, there is a good chance they're going to open up camps. I know a lot of the camp directors, I speak to them personally, are still hoping to open camp in a modified way, potentially in the heat of summer when coronavirus is at lowest risk, potentially with testing beforehand. A lot of that is going to be determined by the Department of Health. But I think they're going to try to open and keep it as much as they can a closed environment where you have minimal people coming in and out. And probably with policies in place too, if your child becomes sick, they have to leave immediately.
Yeah. Oh, very true. So other questions that people are asking, how do I go about accessing the testing? I can offer some explanation at our organization at PM Pediatrics, what we would recommend that you do. Check out our virtual care telehealth app, pmpediatricsanywhere.com. And that way you can get access to a virtual visit with one of us. You might get me, you might get Dr. Weinberg, you might get some other fabulous healthcare professionals, and we can help you screen to let you know what kind of a test that you might need.
Absolutely.
Early, whether it's early in the game and you may need the nasal swab, or whether it is later or you're asymptomatic. And this is for children and for adults. So feel free to check that out. We want to provide that service to the community, and we are starting to do so. So that is one way that we can do it. So another comment that I just want to make, because it came up several times, just to reiterate, the early data suggests to us that children with asthma are not getting affected severely and at more severe rates than other children with COVID-19. So they do not appear to be at risk right now. So I think that that is an important one to know.
Absolutely.
Yeah. Okay. Very good. So another thought. Can you get reinfected? That was what a lot of people wanted to know.
It's a good question. There have been reports, especially out of the places where this started early, like in China, Asia, and Italy, of patients being reinfected. The reports are isolated and low, and we're still unsure if those are cases of reinfection or if there was a false negative at some point in their illness. So to be honest, I think it's sporadic and low at this point, but the potential still exists. The hope is if you do have antibodies to the virus, that even if you do get it a second time, it may be a more mild case of the illness, and it'll just be like a common cold like anything else. That's the hope, but it's still too early to say definitively one way or another. Gotcha.
Is it okay to Lysol gloves in desperation if you don't have surgical gloves left?
Sure.
Let's talk. Let's review the gloves thing, because I think that a lot of people really ask that question. Yeah. And gloves really can do a fabulous job if they are used correctly. Like, right, think about it in the medical setting. We use gloves one time only for one task. We don't go around from room to room to room and use gloves routinely. So as Dr. Weinberg said, if you're going to use the gloves, all of a sudden they become like hands if you don't wash or use them for that one task. Right. So theoretically, could you use gloves? Could you clean them off? Theoretically, you can. Absolutely. There have been some reports, I have not seen anything validated or definitive, that in fact the virus actually will live longer on gloves than hands, and that washing hands, in fact, the oils and the way that there's a little bit of a waxy film on hands is actually a better is better protecting. So I think that's important. Newborns, you want to talk a little bit about what we know in newborns, Dr. Weinberg?
Right. So neonates and infants do appear to be at slightly higher risk of serious illness. The good news is, comparatively to like other populations, it's still pretty low. So they still appear to get a less mild, less rates of serious illness compared with the elderly, for example, but there is a slightly higher risk. That being said, like, for example, there's breastfeeding recommendations that just came out that said you can safely breastfeed your child because most of the transmission is not going to be from the act of breastfeeding, it's going to be from contact. So if you're using a bottle or you're breastfeeding, there's still a potential to transmit the coronavirus to your child. All I would tell you is, for neonates, good hand washing, lots of hand sanitizer. If they have any symptoms of illness, they should be evaluated immediately.
Right, great. When will the antibody testing be available? In select locations, and our offices will be tomorrow. Check back for our website, yeah, to take a look, because that's going live soon. All right, very good. So when, Dr. Weinberg, everybody wants to go see their grandparents, what's
I
your
know.
take on that?
Oh, man, it's killing us. I feel your pain. I
Yeah,
feel your pain. My
yeah,
my grandparents, both sets, or my parents, my kids' grandparents, would see our kids approximately once per week, if not more. And we have not done that since early March, before a lot of the restrictions came into place.
yeah,
To be honest, I am waiting for a couple of things. I am waiting um, for the rate of spread to go down to a very, very low level, um, before I would even consider it. And even at that point, I would only consider it if the state said it was okay. And I would probably do it. I've been trying to picture this in my head for the last 2 months in an outdoor setting with social distancing in place. I don't think there's going to be a lot of hugs in the near future, I'm sorry to say. But I think there is potential to see people from a distance outside and to interact and to connect. I
yeah.
think that potential is there, but we just have to be really careful. It's above 60 and above 70. The data, is scary, and we just have to be safe until we get that vaccine, or, until we demonstrate that the antibody equals immunity. We just have to be incredibly safe there.
Yeah, I think that's right. Another comment that I just want to make, there have been some questions asking about children who have chronic medical problems and illnesses, and are they at higher risk? Obviously, anybody, any child, any age with a weakened immune system or chronic medical problems, by definition, is at increased risk. What I very much am concerned about is that people are waiting, for all kids, maybe waiting to be seen, and we don't want anybody to wait and let symptoms linger. So really use your healthcare professional, use us for guidance, for access into the healthcare system. Totally acknowledge that people do not want to go to hospitals right now and get out, and I totally get that, but there are times when it needs to happen. And so I want people to keep that in mind. So I think that's a really important thing. So this is a terrific question that came up in the Q&A. How does the coronavirus spread exactly, though? If we are wearing masks, not sneezing, washing hands around extended family, how is it really spreading? And so why can't we go and see our grandparents, Dr. Weinberg?
It's a great question.
All the hard ones.
I know. I think, unfortunately, because we're human and we're flawed creatures, and we make mistakes, so yeah, in theory, could you go to their house, never touch anything, never touch them and interact with them in a safe environment? That theory exists. But if you put my daughter near my parents, there's going to be contact pretty soon. So, because they're so close and they have that kind of relationships, and we're humans and we're used to connecting with each other physically. And so that's how this thing spreads. It spreads through contact. It spreads when you touch a surface and then you touch your face. It spreads through, in some small ways, in aerosols. So if you're very close with somebody for a prolonged amount of time, it can spread through the air as well. Again, there's different theories on that. And the overall risk of aerosol spread is low, but it's not zero. And I think it decreases significantly if there's a surgical mask being worn by both parties, but nothing is zero. Yeah. And so, everybody's going to have to draw their line in the sand, to be honest. I don't want you to take my recommendations as mantra and as law. These are just my own thoughts in my head. Could you probably pull it off with surgical masks and being closer to each other indoors? Maybe. The answer is maybe, but it's a big unknown.
Right. Yeah. It's true. We're going to take maybe 10 more minutes for those of you guys who want to be the hanger-oners. And if there's enough interest from this group, we will, I think I can speak for the two of us. We'll knock back on here and
absolutely
and get on again. Yeah. But we don't want to keep anybody up too late because it's a school night. Okay. So a couple more things. Can we clarify the reference to Kawasaki? So here is I'll start and then I'll toss the baton to you, Dr. Weinberg, to add in. And what we know and what we are starting to see in the adult population is that the COVID-19 causes what we call a vasculitis, or inflammation in some of the blood vessels, right? So that's why you're hearing so much about some of the clots, the pulmonary embolus, some of those kinds of things in adult patients. And And so they're starting to see, and the cases have been reported over in Europe. So far, no cases similar to the Kawasaki syndrome have been reported in this country, but it's something that we are watching. And is it possible that children will be susceptible in this same sort of inflammatory, perhaps vasculitis, so inflammation of the blood vessels in that similar way? And that is very possible. That is something that we are watching very closely. Kawasaki is an infection and an illness that is like that, where we see untreated, we see inflammation, specifically in the coronary arteries. Kids who do get treated really do very well, but that is the hallmark and the reference to Kawasaki, that I think the concern is that there may be similar disease mechanisms or inflammatory mechanisms that are causing that. Is that anything to add on that?
Absolutely. The only thing I would add is that these are isolated case reports, and each of these cases is obviously scary and serious. But if we look at the overall rate of this
great point,
new disease process, it's still extremely, extremely low. So I don't want to cause panic. I just want to bring awareness to the possibility that this exists. And if your child is not looking well, to seek care, or if your child has been ill for a prolonged amount of time, to seek care and then decide if a workup needs to be initiated for this.
Yeah. So there have been a couple people asking, and I am not really sure that I know the answer to this, but does this live in chlorine in swimming pools? That's
a good question. You know, right now they're saying there is no evidence that it survives in chlorinated water, which is good.
I will look it up. I'll tell you what, I'll try to find something. I'll put it out on my social channels. So I'm at Instagram, I'm at Dear Dr. Christina. Facebook, here's my plug, Dr. Christina Johns, and on Twitter, I'm at DRC Johns. So I will, we'll try to look this up, right? And I'll put it, I know people are.
But the recommendations I've seen does not support transmission by chlorinated water, which is good for summer.
Right. Precisely right. So why do you think otherwise healthy people with no comorbidity, so nothing else wrong with them, are dying, are getting infected and dying? Great question.
I mean, this is the scary part of this illness. There's a randomness to it that we can't explain, that we don't understand yet. I'm hopeful in 6 months or a year that we're going to figure out what some of these causes are. Is it low vitamin D? Is there a genetic predisposition? Is there something we could do to ameliorate the development of this? Yeah. I'm hopeful. There is so much information and so much research being done. Literally as we speak, there's 100 studies coming out a day on this. So I'm hopeful we can figure this out. But right now it's very poorly understood, and there's a terrible randomness to it, where it can strike, unfortunately, indiscriminately. Again, the overall rate of that is low, especially in kids and young adults, but it does exist, and we need to be aware of it.
Yeah, I think that's right. I do want to point out, though, that in influenza, every year we do see otherwise healthy people who have a horribly tragic course and do die, that we don't really have any real explanation for what was the trigger there. So it is hard to say, but COVID-19 is not the only infection where we see.
Correct.
So I think that's a really important one too. Okay, so comment about nebulizers. Somebody asked if my child uses a home neb, does that, if we use that neb, does that increase the risk and blow everything around? And I have my 60-year-old father who lives with us, and what's the danger there?
So that's a really, really good question. And we've struggled with this in our offices as well. There is that same study that looked at the survival of coronavirus on plastic and metal and so on, also looked at how long it stays in the air. And they used nebulizers in the study to see, and it does appear to survive in the air, sometimes for, especially if it's aerosolized by a machine, for a couple of hours. So I do think, if your child is receiving a nebulizer and there's somebody who is high risk in the home, they should not be in that area, because there is a small risk that the transmission risk would go up with that nebulizer. That being said, if your child has no symptoms, their risk of having coronavirus, it's not zero, but it's low. So I think, overall, obviously, if a child needs a neb, you give the neb. That's always the rule. But be aware that there is a risk if that child has coronavirus of aerosolizing it into the air for a short amount of time.
Gotcha. Yep, that's a good one. Okay, a couple of really quick hits here. Let's talk a little bit, Dr. Weinberg, about isolation. So if you're sick, if you think, if you've tested positive, even if you haven't tested positive, but you've got symptoms that you think are suspicious, what should you do? Who do you avoid, and how do you do it?
Right. So first of all, if there's any vulnerable population in the home, they have to be completely separate from that person if it's feasible. If it's not feasible, then you just have to live and do the best you can. So I think separating vulnerable population from anybody who's sick has got to be number one, if possible. Number two is hand washing. Hand washing is going to be the way that you prevent this from happening. And three, you try to avoid being in close proximity to that person for a prolonged amount of time. So I know there's healthcare providers who are not sleeping next to their loved ones, after any kind of illness because they don't want to expose them. And I can't fault them for that. So I think number one, you have to do what you need to do to take care of your family. That's the first rule. Try to separate the vulnerable population, wash your hands as much as possible. Also get tested, find out if that child or that family member has it. There's testing everywhere, and we need to switch gears and really be aggressive about testing people if they have symptoms, because that's how we're going to prevent this thing from spreading. So if you find out they have coronavirus, you can intensify those isolation efforts and really try to isolate and then speak to anybody who's been in contact with them. But those would be my big ones.
And here's the other thought. Everybody asks me, well, can I take my kids out on a walk in the neighborhood, and
yes.
And do I need to mask them? And the bottom line is, I say, look, bring your mask, right? Can you go out in your neighborhood? Yes. Coronavirus isn't looking to fly into you, so I think that is a really important point. That's a really important point to make.
Yeah.
And so can you get out there? You absolutely can. I encourage people to do so. Try to, I get it, if you're in a congested area, that's difficult to do to maintain that social distancing. But certainly for people who live in a less congested area, you absolutely can get your kids out without concern, as long as you are maintaining that social distancing. When you come back in and wash your hands, do all of the right things that you're being counseled to do, but you absolutely can do that. And so it is, I know a lot of people are afraid to do that, but I think that with being smart about it, you really can.
Be outside as your friend, and as the weather gets nicer, it's going to be a good friend, and we're going to need it for the next couple of months. So I know that people have talked about different studies of aerosolized coronavirus coming out of runners and then floating back into your face. And I think a lot of that is being scared and not smart. I think if you're outside and you're far away from somebody else, your risk of getting coronavirus is extremely low. If you're around other people, wear a mask. If there's no people around, keep it in your hand, keep it in your pocket.
Yeah, that's right. That's exactly right. Okay, gosh, couple last few. Several people talked about, oh, my child had bronchiolitis. Is he now at increased risk? Thoughts about that? No, and I would say the answer to that is there's no data to suggest that.
Correct. We're so early in this, something may come out in the future, but there's nothing to suggest one episode of bronchiolitis puts you at risk, or asthma in young children, as we talked about.
Right. Weakened immune system for any reason, immunosuppression for any reason, then yes, that's concerning. Does eczema or sleep apnea put your child at increased risk? No, it does not necessarily. Okay, can anybody come in and get the test? So again, as a reminder, that if you want to be tested, theoretically, yes, there are people who have had the virus who are asymptomatic, who always were asymptomatic and may be positive. So I think that it is not a crazy thing to think, oh gosh, should I be tested for this? But this is why certainly in our organization, we have tried to set up some very smart screening so that we can help guide people to whether or not it makes sense to get a test, if and when and what kind. And that's coming. And in fact, it's coming tomorrow. So that's the antibody testing. We're already doing the swab testing. Okay, gosh, we had a lot of questions that I know we didn't get to, and a lot of specific ones. talking about going back to school. Maybe what we'll try to do is we'll regroup as a team, and I think there may be interest to do this again, maybe in about a week or so. We can kind of come back on, and maybe next time we'll just try to do a Q&A. Maybe
Yeah,
we'll
let's just do a panel. I think a panel
Yeah,
would be great.
yeah.
Get some of our other experts. I don't pretend to know more than the 50 other, the hundreds of other smart people in our
Right.
organization who are
We'll,
literally sending me the information every day. So we
that's
can
right.
get a good panel up there and answer your questions. We'd love to do it.
Yep, it's a team effort for sure. And so maybe what we can do is next time talk a little bit more about issues surrounding back to school and some things that we can do, should be thinking about, and we can talk that through. So we'll do that. Everybody stay safe, be well. Any questions that you want to, please feel free to send me a direct message on social media. That's probably the easiest access to try to do so. And I will do my best to try to answer. So I wish everybody an excellent night. Thanks for staying up late with us at this pajama party of sorts. Everyone,
absolutely.
Have a great night.
Thank you, everyone. It's been a real honor, and I can't wait to see you again.
Great. Thanks, friends. All right. Night, everybody. Dr. Weinberg, thank you.
Bye, everyone.
Good night.